we have our first question for today. It says that there's a 6-year-old boy. He's brought to the office due to frequent nighttime awakenings. Several times a week over the past month, he has come to his parents' bed around 3 a.m. He was crying. All right. So basically, he had a bad sort of dream. Although he is comforted, he refuses to return to his room. The boy is about to start a first grade. He is healthy, developmental milestones are normal. The sleep state associated with the child's frightening experience occurs in what stage of sleep? What do you think the answer is?
Muscle paralysis. Wait.
Yes, because during nightmares and dreaming, it's in your REM sleep phase, so that's associated with muscle paralysis, isn't it?
I think yes. We have discussed this question already before that I think nightmares occur during the REM sleep, and whereas non-REM sleep is something different than from the REM sleep. We also discussed about the EEG findings in the three stages of the sleep, and where do you see sleep spindles, K complexes, where are the delta waves seen? Again, it's present in the first stage. So kind of go through that table again. Very easy question. All right. Second question we have for today is that there's this 50-year-old woman who has had mild myopia. The patient has no chronic medical conditions. She eats a healthy diet. All right. She's excited because she rarely has to wear glasses or contacts anymore. Visual acuity is 20/30 in both eyes. Which of the following conditions has the same etiology changes causing the patient's visual improvement? I think it's skin wrinkles, but you can.
Yes, with because and Dr. Ahmed explained with the older you get, like in presbyopia and stuff, the loss of collagen due to presbyopia because the lens becomes more concave, so their visual acuity is corrected myopia. So it's something like skin wrinkles because you're getting older, I guess.
Yeah. Again, so it's presbyopia. It's an age-related change of the lens, and so the lens becomes kind of impaired. And that is why what happens is that you see sometimes visual acuity problems as well. And presbyopia, again, it's related to aging. Skin wrinkles also related to aging. So kind of go hand in hand together. All right. What happens in myopia, and what's myopia?
It's short-sightedness. The lens is too large, so the image forms in front of the fovea.
Very good. What do you mean by hypermetropia?
The farsightedness, the lens is too short and the image forms behind the fovea, the retina.
What do you mean by amblyopia?
Ooh, that I do not know.
Anybody else? Amblyopia? Anybody?
No, ma'am.
Okay. Then,
It's a
uh,
lazy eye.
yeah, it's
Lazy eye.
very good. So, amblyopia is a lazy eye. It happens in squint because what happens is that if you do not correct, for example, if you have a squint in the right eye, right, and you do not correct the squint, then what happens is that your brain kind of gets accustomed in such a manner that the eye that's functioning normally, it becomes lazy to vision as well. So it's kind of like a let's just say a reflex that's happening within the brain, and it occurs in patients who are squinted. So you see a lazy eye in those patients. Again, if you don't know anything about it, read about it and let me know tomorrow. All right, we come to the next question. What is this? Where do you see flame-shaped retinal hemorrhages?
Hypertension.
Retinal ischemia.
Like chronic
Like
Is
hypertension.
it can
is it
spread
not in
to
hypertensive?
vision.
Hypertension. What else?
We see that.
So there's a 62-year-old man with a history of poor medical follow-up. He's had blurry vision for the last 2 weeks. A day ago, he noticed a shadow develop suddenly across the visual fields. The patient has had no recent headaches, double vision, vertigo, light sensitivity. On examination, pupils are equal and reacted to light. Again, patchy loss of vision, flame-shaped retinal hemorrhage in the right eye is noted on the fundoscopic examination. Which of the following is the most likely cause of the visual disturbance? So what's happening?
It's glaucoma. Close ankle glaucoma.
It's glaucoma.
No, I think there was retinal detachment followed secondary to some pathology, which I think is hypertension.
Okay. So we say hypertension. Everybody? Yes?
Yes.
Yeah,
Yes.
hypertension.
Yes.
Yeah. Again, so flame-shaped hemorrhages are very classic of hypertension. You need to remember the etiology. I told you guys yesterday as well that the fundoscopy findings are very high yield for USMLE step one. They give pictures of fundoscopy and ask what's that. So you see this retinal flame-shaped hemorrhages. They're very very high yield for in hypertensive retinal hemorrhages. Again, hypertension is a important cause of that. Sometimes you see cotton wool spots. Again, where else do you see cotton wool spots?
Diabetic retinopathy.
Diabetic
Very good.
retinopathy.
Diabetes mellitus. Again, in CREO, you usually see a cherry red spot, which is over here. So this is a cherry red spot. This is very classic of CRAO, central retinal arterial occlusion. What do you see in CRVO?
Engorged vessel. Wings.
What else?
Blood and thunder.
Very good. All right. Again, hypertension in retinal precapillary arterioles. We talked about that. Again, you have a flame-shaped retinal hemorrhages. Sometimes you also see have a cotton wool spot sort of picture as well. But this is usually linked to diabetes mellitus. The reason that they mention it over here is because most of the comorbidities they go hand in hand. So if most likely patient is hypertensive, most of the times they're also diabetic as well. So you kind of see an overlap, but it's mostly distinct in diabetes mellitus patients. All right, we come to the next
I
question.
have a question, Dr. Maheen. I have a question. I'm sorry.
Yeah.
So if in a question in the options we have both hypertension and diabetes in that question, which one would we be choosing?
So in diabetes, you see cotton wool spots. They won't give you this picture in diabetes mellitus. You will have a fundoscopy which will be a yellowish type color, which I'll show you over here. Diabetic cotton wool spots in diabetic retinopathy. You will have a picture. Yeah, this picture I was referring. You will have like a yellowish type of circles. You see this? These yellow type structures will also be present on fundoscopy. You won't be seeing this over here. See, it's very different. You see this? So this will be the difference on the fundoscopy. I told you that they will always give you a fundoscopy. They won't be asking you without a fundoscopy. All right. But cotton wool spots is very distinct of diabetic mellitus. Like I told you, right? You see cotton wool spots over here, but you don't see them over here. But they can sometimes be also present because most of the times these hypertension and diabetes, they go hand in hand. All right. Is it clear?
Yes. Thank
Okay,
you.
got it. All right. What's this?
Josan, maybe?
Drosens.
Trisans, where do you see them?
Age-related
Age-related, yes.
age-related macular degeneration.
Macular
All right.
degeneration.
In dry time.
Okay. A 65-year-old man comes to the office due to vision difficulties. He says his eyesight has gotten progressively worse. Fundus is shown. Which of the following defects is most likely to be revealed by visual field testing?
It's going to be a central scotoma because they usually have central vision loss. Yes.
Okay. Why? Why?
Because there is central vision problem seen in the macular degeneration.
Yes, and due to the drusen and the what's it called, the retinal deposit. So I know there was dry and wet. So that's what it's just central, the macula in the central.
Exactly. So you see that this is the yellowish deposits of lipids and calcium. These are the descents. This is the optic nerve that you can see over here. Again, the older patient who had visual difficulties and had yellow deposits, example, descent, they're all age-related changes, and that is why it's called age-related macular degeneration. Macula usually affects the central portion of the visual field, and that is why it's referred as a central scotoma. Again, what I want you to remember over here is, yes, where is central scotoma occurring? What do you mean by age-related macular degeneration? I think there are two types of macular degeneration. What else are there? What do you mean by, yeah, go on.
Oh, you mean the two types is dry and wet. Wet just to
Yeah.
hemorrhage, and just dry is just the deposit.
How do you treat them?
You give anti-VEGF. Yes, VEGF.
Vascular endothelial growth factor, yes.
Yes.
You give them anti-VEGF, treat those sort of degenerations. All right. What's this?
Papilla edema, optic swelling as well as blurring at the margins.
Okay, let us see. Transient visual changes, loss of vision for a minute. All right, during the past 3 months, she has had persistent headaches that she attributes to migraines, blood pressure, BMI, very classic finding of idiopathic intracranial hypertension. So we know that it has papilledema as well. So I told you guys this. What's the answer?
Elevated intracranial pressure.
Intracranial pressure.
Yesterday, if you guys remember, I told you guys there's that in any sort of intracranial pressure rise, you will have papilledema. So again, we know that it occurs in women. We know it's kind of related to risk factors. What are the risk factors for idiopathic intracranial hypertension?
Obesity.
Obesity.
Obesity. What else?
I think female. Hypervitamin.
Female. Vitamin
Some
A.
medications. Yeah, like
Alright.
tetracycline and is it dinosaur or something?
Great, very good. All right. Yeah, so we talked about this. Again, there's this thing over here, if you kind of read it, that the retinal ischemia also presents with transient monocular vision loss, amaurosis fugax. Do you guys remember I told you that it's also related to sometime atherosclerotic emboli that's launching from the carotid artery? And it's kind of related to the older patients, and that is why I told you that we get a carotid duplex in those patients. So sometimes it becomes hard that if you're talking about carotid artery stenosis or a carotid artery emboli, or we're talking about giant cell temporal arteritis, because they both have amaurosis fugax. All right, I told you guys this, so you need to
Yes, you
remember
do.
this. All right, okay, so what is this?
A Kieser-Fleischer ring.
Kessler-Fleischer rings, very good. Oh, where do you see them? In increase?
Wilson disease.
Wilson's disease.
These are very easy questions. Oh my God.
So it causes basal ganglia atrophy. No.
All right.
This C.
Which of the following conditions will the patient have?
Basal ganglia atrophy.
Yes, basal ganglia atrophy.
Basal ganglia atrophy. Why cannot be a diabetes mellitus?
Associated with
Wilson apposition, and it causes the atrophy of the basal ganglia.
Very good. All right. So we know that Kaiser-Fleischer rings is Wilson's. I think there was this mnemonic kind of, I forgot it, but what was, oh yeah. So you identify Kaiser-Fleischer rings through slit lamp examination, very high yield for you to remember this. Again, it's a classic picture. It's also tested on NVMEs. Again, it's because of excess copper, so you kind of give copper chelators such as D-pencilamine. Just remember D-pencilamine, it's very high yield. They do not ask triennitate on this, so just go through D-penicillamine. It kind of helps break down excess copper. And yeah, so again, we talked about this. All right, so any patient who is young and is having Parkinson's type symptoms, it's most likely Wilson's on step 1. All right. So just check the age. Any patient who presents with symptoms like Parkinson's and is a young patient on USMLE step 1, step 2, step 3, they are most likely talking about Wilson's. All right, just remember that. Okay, what is this? We talked about this.
Cherry
red spots.
CRAO.
CRAO, very good. Again, no need to read the upper portion. Which of the following is most likely cause of the patient's loss of vision?
Central retinal artery occlusion.
B.
See, we know about that. See, so this is why I help you focus on the pictures, because this we don't need to know. We saw the picture, was like, okay, what's this CRAO? Move on to the next question. This helps you save your time. All right. Okay. Next question for today is that fundoscopic examination shows bilateral optic discolor, attenuation in retinal vessels, and areas of dark discoloration in the retina. I told you guys this. 17-year-old boy, poor vision at night. We discussed this yesterday. Poor vision night, mild difficulty seeing, visual field shows a loss in the mid-periphery, external eye shows normal tear formation, bilateral optic discolor, attenuation of retinal vessels, area of dark discoloration. What is this?
It's retinitis.
Retinitis pigmentosa.
Yeah. And what did I tell you? What's the link with? I told you guys this yesterday.
Mhm. It is the genetic progressive retinal dystrophy.
Okay. So what do you think the answer is?
Yeah, B.
B?
B.
Right.
Yeah, it's genetic.
So it's genetic. We discussed about that. Again, patients will also have loss of rods. That is why they have night blindness. Along with that, they have loss of cones as well, which usually occurs in a later finding. Again, you will be having retinal visual attenuation, but the most classic is dark discoloration of the retina, which means it's getting pigmented. So kind of it's a giveaway word, retinitis pigmentosa. Again, we talked about that. So we talked about CRAO, we talked about acute closure glaucoma yesterday. We also talked about papilledema as well. We know what retinoblastoma is, right? In what tumor do you see retinoblastoma gene activation?
Osteosarcoma.
Osteosarcoma, very good. All right. Next question we have for today is the patient also received routine prophylactic medications, including erythromycin, ophthalmic ointment, and IM vitamin K. Why do you give IM vitamin K at birth?
Because of neonatal hemorrhages, to avoid the risk of neonatal hemorrhages, because the gut of the neonate is very sterile. So that's why we have to give the vitamin K.
Very good. Ophthalmic examination shows abnormal retinal vascularization that extends into the vitreous. The retinal findings in this patient are most likely related to which of the following? So we have a 4-week-old boy. He comes to the NICU. The patient was born 29 weeks gestation. Immediately before delivery, the mother received a dose of terbutaline in an attempt to stop the contractions. All right, along with dose of steroids. Shortly after birth, the patient developed severe RDS. Requiring surfactant administration at supplemental. Oh, what do you think is the answer?
It's retinopathy of
Oxygen
prematurity. Yeah, oxygen.
Yeah, neonatal
your
retinopathy of
oxygen
premature treatment.
VEGF. Yes.
Very easy. Neonatal oxygen supplementation causes free radical damage, and that is why I think it causes free radical. I don't know. I've forgotten step 1. I gave it a long time ago. Yeah. So most of the times it does cause free radical damage, and that is why it causes a retinopathy of prematurity in patients who are in premature neonates. Again, all right. So you don't give them again all of these. Why do you give erythromycin? Yes. Why do you give erythromycin? To prevent what?
Conjunctivitis.
Of what?
Can it
Gonofocal?
be a conjunctivitis?
Gonorrhea.
Gonofocal. So you give erythromycin to prevent
Gonococcal.
gonofocal
And
conjunctivitis.
clindamycin,
So a neonatal ophthalmic antibiotic treatment is erythromycin. It prevents gonofocal. It does not prevent chlamydia. For chlamydia, you don't give drops. For what do you give for chlamydia?
ceftriaxone, I think.
What else?
Metronidazole.
Very good. All right. Then we have a next question for today. The appropriate therapy is started including medication to treat a bradycardia. I think we talked about this. Yeah, we talked about this. So we're not going to do this again. Okay. Physical examination is unremarkable except for an anisocoria. What do you mean by anisocoria?
Unequal pupil
Different size of
size.
pupil.
Unequal pupil
Asymmetry of
size.
pupils.
Okay. So the migraine headaches, she's a woman, and physical pupillary examinations are findings in normal, bright, and dim light, and they're shown below. Okay. The patient's pupillary abnormalities is likely to a defect to which of the following pathways? What's happening?
There's a problem with constriction in meiosis under bright light of the right eye. So it's going to be parasympathetic problem of the right eye.
Parasympathetic is sympathetic.
Parasympathetic, because
para-
parasympathetic is for constriction and sympathetic is for dilation mediasis.
Very good. So again, you guys know the concept. You guys are doing it exceedingly well. So anterior chorea, they're the asymmetrical pupils. We talked about that. It's caused by a lesion in the ocular parasympathetic constriction or sympathetic dilatation pathways. Again, the what do you mean by RAPD? What's RAPD?
Sorry, can you say again, please?
What do you mean by relative afferent pupillary defect, RAPD?
Optic nerve problem, because the afferent is through the optic nerve, second cranial nerve.
Where do you see RAPD?
If there is the optic nerve lesion or the problem,
In what condition?
it could be in the multiple sclerosis
Very good.
and the lesion of the optic nerve, if there is, or
Tumors.
the tumor, pituitary tumors,
Very
they
good.
could cause the optic chiasma compression. And yes,
Yeah, so it's like a clinical thing that we do, that when the light is shown in the affected eye, no signal is transmitted, but as a result, the pupil constriction. So the pupil constriction is equally impaired bilaterally, all right, because due to the defect in the visual pathway, and it occurs in conditions like as multiple sclerosis as well. So you see RAPD and MS as well. All right. Okay, so what's this? The patient has a prolonged history of hypertension, hyperlipidemia, type 2 DM. Blood pressure is very high. Okay, pulse is okay. Neurological examination, including visual acuity, is normal with the exception of the ocular findings shown in the image below. What's happening?
Intranuclear ophthalmoplegia.
Yeah, sympathetic.
yes, intranuclear ophthalmoplegia
There's
because of
problem
the
with rightward gaze.
MLO,
Well,
medial longitudinal fasciculus problem.
well, yeah. So again, intranuclear ophthalmoplegia, it's a very easy concept. The patient has intranuclear ophthalmoplegia, which means it's a disorder of the impaired horizontal gaze. It's because of the damage of the MLF, that's medial longitudinal fasciculus. Again, just remember this. Do not go into the dynamics of it. Just remember what type of gaze is affected. The pathways for convergence and the pupillary right reflex, it bypass the MLF lesion, and that is why those reflexes are preserved. Again, easy topic, nothing to be kind of. All right, okay, then we go to the next question. Fundoscopic examination reveals scattered retinal microaneurysms, dot and blot hemorrhages, cotton wool spots, as well as new blood vessel formation. Which of the following contributed to most of the pathogenesis of the patient's current ocular condition? 68-year-old woman, vision impairment. Okay, she has diabetes, hypertension, CKD, blood pressure is a little bit high. Anterior chambers are clear. What do you think is happening?
Yeah. Here is the
Chronic hyperglycemia.
diabetic nephropathy, diabetic retinopathy,
Very good.
chronic hyperglycemia induced microvascular injury.
This is a classic case. I told you that you will see dot and blot hemorrhages. You will also see cotton wool spots. New blood vessel formation is also occurs in the diabetic retinopathy. Again, there are a lot of types of diabetic retinopathy. I'm sorry. Okay, so there are a lot of other types of diabetic retinopathy. You have non-proliferative, proliferative. Usually, they don't ask you the stages, but just kind of go through that. If in proliferative, you have probably neovascularization, formation of new vessels. Whereas in non-proliferative, you did not have that. Just kind of go through the overview. They do not ask about that in great detail. What's the treatment for diabetic retinopathy? What's the treatment?
Anti-VEGF,
What else? What else do you do?
laser,
Laser, and control the medication regimen. You add in one more hyperglycemic medication. All right. Okay. Then we come to the next question. All right. Blood pressure 140 by 86. Pulse is okay. Physical examination. Right pupil is 3 mm and the left pupil is 5 mm. Again, same thing. Ansiochoria. What's that? We talked about it.
Yes, problem is either parasympathetic or sympathetic. And when the light, it is if the anisocoria increases in dim light, so it's going to be a problem with sympathetic. And
Yes.
since the 3 mm did not, if it increases, that means the left eye dilated more. So it's going to be the right oculomotor sympathetic pathway will be affected. E, I think.
Yes.
Yeah. Again, we talked about that. What's ansiochoria? Why? What's happening in that? Again, it's a unilateral defect from either the oculosympathetic or the parasympathetic pathway. In response to the dim light from the oculosympathetic pathway, it initiates pupillary dilatation, allowing more light to reach the retina. Again, under the bright light, parasympathetic input from the ipsilateral oculomotor nerve, it initiates pupillary constriction, limiting the amount of light received by the retina. Again, a very concept-based question. I loved eye. I always wanted to match into eye residency, but unfortunately, it's very difficult for international medical graduates to match in ophthalmology. But yeah, I loved it. Okay, next question. However, she says he has been complaining of intermittent headaches, memory loss, vision disturbances for the past 2 weeks. Brain imaging shows a solitary mass within the right temporal lobe. Which of the following visual defects, areas of vision loss in the back is most likely present? So, a patient basically has a tumor within the right temporal lobe. What's going to be affected?
If it's temporal, it's going to be quadrantonopia. It's going to be pie in the sky.
All right.
Then pie on the floor. Pie on the floor is parietal.
D.
D.
Because it involves the superior loop of the optic radiations. The superior loop will be affected. Yes.
Exactly. So we know that in this, the inferior optic radiations that travel through the temporal lobe with the mirror lobe, and they carry information from the inferior retina, which covers the superior visual field. Again, we know temporal lobe lesions result in contralateral homonymous superior quadrantopia. This is a very high yield thing. You know, these pictures, you need to be familiar with what each and every one of it doing. So what is A?
Optic nerve.
Ipsilateral anopia because of optic nerve.
Bitemporal hemianopsia optic chiasm. D.
Very good. What do you mean by B?
Bitemporal hemianopsia, optic chiasm compression like pituitary adenoma.
Very good. What do you mean by C?
Homonymous hemianopia. Homonymous.
Optic tract involvement.
Then
Where do you
E is pie on the floor. That's for parietal lobe lesions.
Very good. All right. We did this question. All right. Fifth question. The patient uses an albuterol inhaler for occasional wheezing. Ophthalmologic examination of the right eye shows a grayish discoloration of the macula with areas of adjacent hemorrhage. Which of the following should be specifically targeted in the treatment of the patient's condition? 67-year-old smoker comes to the hospital because of blurry and distorted vision. The patient has been having vision problems over the past year, and these have made it most difficult to drive, and it required that he uses a bright light to read the newspaper. He has no histories of DM and hypertension. The patient uses an inhaler. What do you think is targeting? What do you think the answer is?
VEGF,
To avoid the hemorrhages, VEGF should be given. Yes.
All right. So we talked about this, how in age-related macular degeneration we give VEGF, vascular endothelial growth factor, and they kind of help us curb down the excessive. So this is what bevacizumab is very high yield for. You don't remember bevacizumab? It's very high yield. They don't ask you about ranibizumab. They do ask you about bevacizumab. So just remember Beva. It has a V in it. So VEGF inhibitor. All right, Eva, VEGF inhibitor. All right. Okay, so we discussed this. Then we come to the third question. Okay, this is the last question for today. Medical history is insignificant. A complete physical examination is performed, including a full neurological assessment. Shining light into the patient's right eye causes constriction of her right pupil, but not of the left pupil. Shining light into her left eye causes constriction of only her right pupil. Which of the following additional physical examination findings likely to be found in the patient? What's happening? So a 34-year-old woman, she comes to the office due to double vision. The patient's first experienced difficulty focusing in her eyes while at work yesterday. On awakening this morning, her symptoms have progressed to flank diplopia. What's happening?
It is the relative afferent pupillary defect.
Yes, the left eye,
Is it pupillary?
oculomotor nerve is affected here because the right eye is okay because it is having the constriction, but the left is not, and the left reflex is not, means the left oculomotor nerve is not fine. So the left sided function of the oculomotor will be the uh, uh, it causes the drooping of eyelid, left eyelid, ptosis.
Okay. So we all agree with B. Yes. So again, oculomotor, these are very high yield for you. Remember, I talked about that, how eye muscle innervation, lesion findings, and oculomotor functions are very high yield for you to go through. Again, although the most common cause of acquired oculomotor nerve palsies are DM and hypertension, the patients are often evaluated with neuroimaging to rule out any aneurysms within the PCOM and can present with isolated cranial nerve 3 palsy. We talked about that they also have a down and out pupil. So sometimes PCOM aneurysms can also cause down and out pupil. You also have to do a CAT scan of the brain to kind of see what's going on. And you also have an efferent pupillary defect, and you also have ptosis along with it. So yeah, I think that comprises our module for today. And we're done for today. Yeah, do you have any questions? You guys can ask me. No, then Dr. Ahmad will be taking over the class. No? All right, Dr. Ahmad, you here?
Yes, Dr. Maheen here. Thank you so much for having such a great session. And yes, do anyone have any questions? Hello?
No, thank you.
Okay.
Yeah, I think they don't. So I will be leaving, and I'll see you guys tomorrow. Dr. Ahmad can take over.
Thank
Okay,
you.
Right, bye.
thank you. Thank you, Dr. Maheen. Okay, so we'll be starting our session within 5 minutes. And we have very little participants. Okay, let me just check in the group why are we having so less participants. You guys can also drop down the message in the group because we do not we want such low participants, right? We'll be starting our session within 5 minutes, right?
Okay, doc.
Hello? Can you guys hear me?
Yes, sir.
Okay. So today we are going to start our okay, just give me a second. We are going to start our air module. We already have done our I. Okay, let me just share my screen. Can you guys see my screen?
Yes.
Okay. Okay. So first of all, we are going to discuss a little bit anatomy, right? Anatomy of your ear. So we are already aware that basically the ear is divided into three parts, right? Our external ear, the outer, middle ear, and inner ear, right? So we already know that external ear basically consists of auricles, which is also known as spina. You guys are aware of that. And then we have like external auditory canal, and like this is your ECA, external auditory canal. Then we have our middle ear, right? And there are certain components within the middle ear. If you guys know, like for example, if you have a tympanic membrane, to the tympanic membrane basically our ossicles are going to be attached, that is malleus, incus, and stapes. Okay, so this is going to be your middle ear. And we also have, then we have our inner ear, right? So inner ear basically consists of cochlea, and it also consists of semicircular canals, right? So we have three semicircular canals which are important, or which are basically responsible for your balance, right? And cochlea is basically like responsible for your hearing. So you guys are already aware of that, that the stapes is basically attached to oval window, if you guys remember. So whenever we have like any hearing sensation, it would strike upon the tympanic membrane, and tympanic membrane in turn would just activate like these ossicles are going to vibrate, and they are going to they'll be attached to the oval window, and in the oval window it's going to stimulate endolymph and organ of corti, and from the organ of corti we have our nerve going on, which is going to enter into brainstem. You guys are already aware of this pathway, right? So we have our external ear, we have middle ear, and we have inner ear. So they are basically the cochlea and the semicircular canals are component of your inner ear, right? You guys also know that your middle ear is basically connected with your, yes, with your nasopharynx wire tube, which is known as eustachian tube. You guys already know that, right? And what's the function of eustachian tube? We already know that function of eustachian tube is to like maintain the pressure within the middle ear, right? But we also know the fact that in certain group of individuals, for example in children, we have more horizontal configuration of this eustachian tube. So we can have bugs from the nasopharynx that can just travel back due to its horizontal position, and it can cause middle ear infections, which are basically known as, this condition is known as otitis media. Is that clear? Hello?
Yes.
Yes,
Okay.
yes,
So we
son.
have, okay, let me just repeat again. So we have three parts of our ear, right? Outer ear, which basically consists of the pinna, the visible part. We have our auditory canal, external auditory meatus or external auditory canal, right? Then we have our tympanic membrane. Our middle ear, basically it's like ear filled space. We already know that. It's in continuation with your eustachian tube, with your nasopharynx. And we have ossicles. Ossicles are basically three small bones, right? Your malleus, incus, and stapes, right? Okay. So then we have our inner ear. Inner ear basically consists of cochlea. We have, if you guys remember further, the cochlea have like a basilar layer. On the basilar layer, we have our organ of corti, and they're attached to like a tectorial membrane. And once they keep on vibrating, so they're going to send signals, right? Okay. So we have like here cells in the cochlea, and this is like the entire configuration. Is that clear? So this was a little bit about anatomy, right? So let's discuss a condition which is known as otitis externa. So do you guys know what is otitis externa?
Yeah,
Yes.
inflammation of the external auditory meatus.
Perfect. So otitis externa is basically inflammation of external auditory canal or external auditory meatus, right? So for example, if we have inflammation here. Okay, so you guys should know that basically like most of the part of external auditory canal, let me just give you an overview. Like half of it is like cartilaginous in nature and then half is bony in nature. Remember, within the cartilaginous part of external auditory meatus, we have ears, right? We have ears. Is that clear? And they also produce something which is known as wax, right? So wax basically have a substance which is known as cerumen, right? So they are like modified apocrine glands basically, which makes cerumen, and which is very important here in order to keep an environment within the ear which is like, you know, in which the bacteria cannot survive, by the way, right? So we have hairs there as well. So sometimes what happens, these hairs can get inflammation, right? The hair cells and the follicular cells here can get inflamed, right? So it can also give you a kind of inflammation. Okay, what is otitis externa? Whenever we have like inflammation of external auditory meatus, right? But the most common bug which cause otitis externa, yes, what's the name of that? What do you guys think?
Pseudomonas.
Yeah, Pseudomonas, right? And it's a very fatal infection. Like we can have, it can also lead to a condition which is known as malignant necrotizing otitis externa, right? In which we have invasive infection which can spread to the bones as well. So what happens basically, the infection with Pseudomonas is mostly seen in those individuals like who lives in a humid environment, right? Like for example, in the swimmers, right? So in the swimmers, we can have like this condition due to Pseudomonas. They can develop otitis externa, right? And as a result of that, what happens, the ear canal can have occlusion, right? And right after that occlusion or trauma to the ear canal, we can like a person can also end up using like hearing aids, right? Okay, so then we have another condition that is malignant necrotizing otitis externa. So what is malignant or necrotizing otitis externa? Like it's a malignant condition. It means it's a more fatal. It would spread. Malignant basically means spreading, right? So malignant otitis externa, basically we are going to have this infection which is going to spread to your bones, giving you osteomyelitis. Is that clear? So the complication of otitis externa can be malignant otitis externa, like it can spread, right? And it can just give us a lot of pain as well, which is known as otalgia. Like we have a sign which is known as tragus sign. So what is tragus sign? If you guys know that we have we have a part of ear, like for example, if this is our external auditory meatus, so you have a flap kind, you know, a tragus. So what we are going to do, we are going to push the tragus, and if an individual have like pain, so basically we just term that we have positive tragus sign, right? So the tragus sign in this individual is going to be positive due to pain, due to the necrotizing infection which is spreading and which is causing a lot of pain. Is that clear? Hello?
Yes.
Okay, perfect. So let's discuss our next condition, that is otitis media, right? Otitis media. So can you guys just tell me what is otitis media as the name suggests?
Inflammation of the middle part of the
Middle ear.
Perfect. So it's basically inflammation of your middle ear. But like seeing the anatomy, we discussed that we have a eustachian tube, which is basically, you know, which basically attach your middle ear to your nasopharynx, right? And we discussed that in children age group, what happens that whenever they are less than 2 years, they have more horizontal configuration of your eustachian tube, right? So the bugs from the nasopharynx can just move back through the eustachian tube, and in the middle ear it can cause infection, right? So can you guys just tell me which bugs would be responsible for causing middle ear infection that travel through?
Haemophilus influenza.
And Moraxella.
Streptococcus.
Haemophilus, yeah.
Okay, perfect. So we have H influenza. Okay, we have strep pneumoniae, and we have Moraxella, right? So what happens, they can spread like back through the eustachian tube. Like for example, basically we have two muscles which are like responsible for closing of your eustachian tube as well. That is tensor palatini, villi palatini, and what else? Hello? Yes. Anyone?
Tensor tympani?
Is it tensor tympani? It's something.
What are you asking? Sorry, sir.
Tensor palati.
Okay, tensor
Palati.
palati. They basically, it helps in closure of your eustachian tube. Okay, what's the name of other? You can just search it, right? Tensor palati is one of the muscle.
And the levator, I think.
Yes, levator.
Levator
Palati,
palati.
right? Yes. So both of these muscles basically helps in opening. Okay, basically that helps in opening of your eustachian tube, right? So if we have problems with these muscles and the eustachian tube remains open, for example, so it can also lead to otitis media, right? And basically, what's the other function of otitis media? That otitis media basically, like, you have well pressure which is maintained through the nasopharynx. So for example, if you have obstruction here, so it can also cause problems, right? So
yes,
what happens that in otitis media we are going to have infections which spread back. You already know it, right? So
yeah, and there will be bulging tympanic membrane.
Yes, bulging of tympanic membrane as well. If we have infection going on here, so for example, with otoscope, if you see the tympanic membrane, it would be red and it would be bulging out, right? It will be red and bulging out. Okay. So we have a condition which is known as mastoiditis, right? So anyone know what is mastoiditis? What is mastoid, by the way? Yes.
It's a
Part of the
The
temporal
bone behind the ear.
Like behind the ear, you have a cavity, or we can say a mastoid, right? So it's basically, okay, so your inner, like for example, if this is your ear, so it's also connected with your mastoid antrum as well, right? So that is structure is basically known as mastoid antrum. So sometimes the infection can go back to the mastoid antrum as well, and it can cause problems, right? So the inner ear infection can also spread through the mastoid process, which can cause mastoiditis, right? And the individual having mastoiditis, as the mastoid process is basically present behind the ear, so he'll be having post-auricular pain or erythema and swelling, right? Is that clear?
Yes, sir.
Okay, perfect. So we have our next condition, that is common cause of hearing loss, right? So the most common cause of hearing loss in individual is noise-induced hearing loss, right? So you have a word MCQ on that as well. Noise-induced hearing loss. So how do one have noise-induced hearing loss? Like for example, if you have an individual is living in such an environment where we have like loud noises. So what happens? Loud noises basically damages your organ of corti. So what are organ of corti? Yes, you guys are going to tell me that.
this is a micro organ which present in the inner ear, and is having you already described its structure. Is having a tentacular, and is having some cells, ciliated cells, and in the base of them there will be some nerve fibers which connect. Yeah.
So as we discussed, in the cochlea, we have a structure that is a basilar membrane. We have hair cells which are basically present on the tectorial membrane, and whenever they moves along here along the tectorial membrane, they are basically going to depolarize or hyperpolarize the nerve which is going to leave here. So basically, this part is known as organ of corti, right? So due to increased noise, organ of corti can be damaged. And as a result of that damage, we can have loss of high frequency hearing, right? So first of all, the high frequency hearing is going to be gone, right? And then suddenly extreme loud noises can produce hearing loss due to tympanic membrane rupture as well. So we already know that increased noise can cause two problems. First of all, it can cause damage of your organ of corti. What else? It can also cause damage of your tympanic membrane and rupture. And once the tympanic membrane is ruptured, we can have further conductive hearing loss, right? Then we have another phenomena that is known as presbycusis. So can you just tell me what is presbycusis?
Age-related hearing loss.
Perfect. So it's basically age related. Okay, is it bilateral or it is like unilateral?
Bilateral.
Bilateral.
Bilateral,
Perfect. So
symmetrical.
it's going to be bilateral, age relative, progressive, right? It would progress. It would be gradual, right? Hearing loss. Okay. And why do we see that? It's due to destruction of the hair cells, right? So whenever these hair cells are damaged, we can have this condition which is known as presbycusis, which is normally seen in older individuals, right? Okay. So these were some common causes of hearing losses. So let's discuss some diagnostics. So you guys are going to tell me about Weber and Rennie test, right? So that's very easy. You guys might have done it a lot in your OSCEs. So yes, Dr. Daniela is going to tell us about Weber test. What is Weber test?
Hello, can you hear me?
Hello?
So yeah, can you hear me? Sorry, can you hear me?
Yes.
So web says we use it to check for we have bone conduction and what's it called? Air conduction of
Okay.
hearing loss. Yes.
So can you just tell me, like, normally the bone conduction should be more or air conduction should be more?
Normally what's it called? Air conduction.
Yes,
Bone
normally air conduction is
is
more
more.
than bone conduction, right? So
Mhm.
how do we perform Weber test? You guys are going to be telling me that, yes?
So we use a tuning fork, striking the tuning fork. We place the tuning fork like conductive on the forehead, like right. Like
On the forehead or on the mustard process?
mastoid mastoid process, sorry.
Yes,
That was air
for the
is for
Rennie test.
rainy, sorry, yes, mastoid process.
Okay. Then what? What else?
I
I
can't
think we,
remember this very well, sorry.
Weber,
Just
Weber is
I
In
think
on
front
the
of the ear.
Weber in
In
the
front of
forehead,
the
Doc.
ear.
Weber is on the
Yeah.
Weber
forehead.
in the
Please,
forehead.
one by one, please.
Dr.
Okay, Dr.
Weber is
Shafiq.
before.
Yeah,
Yes, Dr.
Weber will be in the forehead, but the Rennie test will be in the back of the ear, in the mastoid process.
Okay. Okay. So you're saying that, okay, Weber will be on the forehead, or you can also do it on the head, right? And Rennie would be on the mustard process, right? So first of all, we are going to strike a tuning fork. We are going to place it on the mustard process, and you are going to tell an individual, once you just stop hearing, like the vibration, you are going to tell me. So he's going to tell me, yes, now it stopped. Then you are going to take that the tuning fork and place it through, like, in the external auditory meatus. If still he can hear, it means everything is fine, right? But it means that the air conduction is more than bone conduction. Are you guys getting me? If like he stop hearing at the mustard process, and right after that you place the tuning fork on the external auditory meatus, and still he is hearing, it means that air conduction is more than bone conduction, everything is fine. But if he isn't hearing, it means there is some conductive deficits. Is that clear? Conductive hearing loss.
Yeah.
Yes, Doc.
Okay. So what about Weber test?
Weber test, we will put the fork in the middle of the forehead, and if there is some
Okay. If we have conductive hearing loss, so what do you think? You are going to see lateralization of sound. Where?
in the normal ear.
In
Affected
the
ear.
normal,
Conductive
or
ear.
normal ear or
Affected ear.
affected ear?
Affected.
Affected
Affected
ear.
ear. In the
Yes.
affected, yes, yes.
Yes. Why in the
Because
affected? Because
no air
all of the
conduction.
external sounds are going to be cancelled, right? Because he have conductive deficit, and now he can well hear the bone conduction through his affected ear, right? So it was
Yes,
all about
absolutely.
Weber test and Rennie test, right? So he's going to give me an overview again. Yes, Dr. Danila is going to tell us again what is Rennie test and what is Weber test.
so for Weber's test, like we said, we'll strike the tuning fork and placing it on the forehead, right?
Mm-hmm. Okay.
And sorry. And for Raynaud's test, we strike the tuning fork and place it on the mastoid bone.
Okay.
And in Raynaud's test, because the problem in conduction, bone conduction, sorry, the problem is going to be lateralized towards the problem, the area with the hearing problem, not the hearing loss.
Okay. Okay.
That's what I
Okay.
said.
Perfect. Okay. So let's discuss our next condition, that is cholesteatoma, right? So can
Dr.
anyone
Amla,
just
can you repeat it?
okay? Okay, we'll repeat it. Don't do it, right? So what happens? Basically, we were discussing Rennie test and Weber test, right? So what do we do in Rennie test? Basically, we are going to take a tuning fork. We are going to strike it. We are going to first of all put it on the mustard process, and we are going to tell an individual once you just stop hearing the vibration, you're going to tell us, right? So you will just tell us that yes, the vibration is stopped. Then we are going to take the same tuning fork and place it like in the ear, external ear, right? Like in the pinna or the external auditory meatus. If still he can hear it, it means that the ear conduction is greater than bone conduction and everything is fine. If that individual cannot hear like through the external auditory meatus, it means there is some conductive hearing loss, right? Like for example, there can be problems with the tympanic membrane, there can be problems with the ossicle, all of that, like helps in conduction or giving you conductive hearing, right? What is then our Rennie test? What do we do in Rennie test? We are basically going to put the striked tuning fork on the forehead, right? So we are going to hear more, or we are going to hear like see lateralization of hearing to the affected ear, right? Why to the affected ear? For example, if an ear is having conductive hearing loss, so to the side of conductive hearing loss, we are going to hear more sound. Why? Because at that side, basically you have conductive hearing loss. It can be due to damaged tympanic membrane, ossicles, and due to that reason, all of the external voices are going to be cancelled. So you can well hear the bone conduction is going to be like more, right? The bone conduction is going to be more. So you're going to hear more on the affected side. Is that clear?
Okay. I thought bone conduction will be by touching from the by tuning fork. Tuning fork was touching forehead, so I thought it might be affecting hearing through conduction.
Okay, so affected ear is going to have like more hearing, right? Okay, so we have a condition which is known as cholesteatoma. So can anyone just tell me what is cholesteatoma? Yes.
Squamous, keratinized squamous cells being present in the middle ear.
Okay. If we have keratinized squamous epithelial in the middle ear, so what would happen as a result of that? Yes. Okay. So if you guys know that we have our tympanic membrane, right? And the tympanic membrane basically have two parts. We have the flaccid part and we have the tense part, right? Which is also known as pars tensa and pars flaccida, right? So remember what happens normally, like for example, if this is our external auditory meatus, and let's suppose this is the pars flaccida, like part of your tympanic membrane and pars tensa. So sometimes what happens that, for example, if an individual is having, like, we can have primary or secondary cholesteatoma, right? So for example, you guys already know that the external ear is basically lined by keratinized squamous epithelium, right? So sometimes what happens, this keratinized squamous epitheliums can, it can like overgrow, it can like abnormally grow, and it can enter through the pars flaccida. And once it just accumulate within the pars flaccida, so the pars flaccida is basically a flaccid part of your tympanic membrane. So it can form a pocket, right? And due to abnormal growth of this keratinized squamous epithelium, again, this pocket can increase in size. And once it's increased inside, it can spread everywhere, right? Even it can cause problems within the middle ear. It can spread like to the antrum side. It can cause the ossicles to erode. Are you guys just following me? It can cause ossicle erosion. And once the ossicles are eroded, it can lead to extreme conductive hearing loss, right? So there are two variants of cholesteatoma. Either the primary, which is basically like congenital, and it can be secondary. So this one which we discuss is the primary, in which we are going to have the traction pocket, which is going to enter back and do, right? It's going to like go back, and it's going to have overgrowth of your keratinizing squamous epithelium, and then it can cause problems, it can cause erosion, right? So secondary acquired is basically due to tympanic membrane perforation, right? So for example, normally the tympanic membrane perforation is like here, right? So for example, if we have an individual, he's having like tympanic membrane perforation due to chronic otitis media. You guys know that the tympanic membrane can rupture, right? And it can lead to perforation. So what happens sometimes in the secondary variant of cholesteatoma, these keratinizing squamous cells again can enter into the middle ear through this perforated part, right? And once it keep on like, overgrowing there, again, it can cause formation of cholesteatoma, right? Which is basically known as secondary variant of your cholesteatoma. And there it can cause problems. Again, it can cause like, it is basically a painless condition, right? So again, it can cause erosion of the bones, the ossicles, which is going to lead to conductive hearing loss. Is that clear? Cholesteatoma. Let me just give you an overview. What is cholesteatoma? It's an abnormal growth of keratinized squamous epithelium in the middle ear, right? So we have two variants, congenital, the primary, and secondary, right? Why do we have primary? Through the pars flaccida, if we have increased overgrowth of keratinized squamous epithelium, it would just form a pocket. It would just form a retraction pocket. This retraction pocket is going to grow again. It's going to spread through the middle ear. It's going to cause problems with the ossicles. The ossicles can be eroded, which can then lead to conductive hearing loss, right? What else? We have secondary variant of cholesteatoma. What happens in secondary? If an individual is having chronic otitis media, the membrane, the tympanic membrane can rupture. It can have perforation, permanent perforation, right? So sometimes what happens due to overgrowth of keratinized squamous epithelium, it can enter through that perforation into the middle ear. And again, it can cause problem there. It can cause erosion of ossicles. And this condition is known as cholesteatoma. Is that clear? Hello?
Yes, sir.
Yes, sir. Thank you.
Yes, so who is going to give me an overview of cholesteatoma, its primary and secondary, a quick overview. Then we are going to discuss our last condition, that is vertigo. And with that, we have finished the special senses. And tomorrow, then we are going to have like a lecture on pharmacology. Dr. Taha will be joining that, and we'll be having a bootcamp session right after that. So can anyone just give me a brief overview of cholesteatoma? What is cholesteatoma and its different types?
You said abnormal growth of the keratinized squamous epithelium in the middle ear.
Okay, perfect.
And you said there's primary and secondary. Primary is congenital and secondary is acquired.
Okay, yes.
The primary being congenital will be due to the tympanic membrane forming a pocket or retraction into a pocket due to like what's it called, eustachian tube dysfunction. That's what you said.
Yes, eustachian tube dysfunction can also, yes. We are also going to have eustachian tube dysfunction as well. So what would happen? That traction pocket is going to grow. It's going to cause problems. For example, erosion of your ossicles.
Yes,
the main problem here is going to be erosion of your
erosion, and that erosion will now lead to conductive hearing loss. So that's what the erosion.
Yes, perfect. Okay.
And
so now we have. Okay, just give me a second. What happens? Okay. So let's discuss our last topic, that is vertigo. So you guys are going to tell me what is vertigo.
Sensation that you're standing in a stationary position, but then you feel like the world is spinning, so everything is spinning. So it's a form of dizziness.
Perfect. So vertigo is basically sensation of spinning while an individual is stationary, right? So we can have we have two main variants of vertigo, which you guys have to know, right? So we have peripheral vertigo and central vertigo, right? So as we discussed that our semicircular canals are important for your balance, right? So for example, if we have problems there within the like semicircular canals, what can be the problem, right? So sometimes you guys know what are otoconia? Do you guys know what are otoconia?
No.
Okay. So as we discussed that, for example, these are our hair cells, right? And the hair cells are basically present on the tentorial. You have a tentorial membrane, and there are like a carbonated kind of small stones present, which are known as otoconia, right? And against which basically your hair cells are going to rub, and it's going to cause depolarization and hyperpolarization, and in turn we can have like formation, or the vestibular part basically is going to send the signals for balance, right? So sometimes what happens, these autoconias can detach from its part and it can enters into the semicircular canals, right? So once these autoconia go into the semicircular canals, now they'll be called as otoliths, right? Otoliths. Is that clear? And once those otoliths, those bony like carbonated stones are present within the semicircular canal. So for example, if an individual is changing his head position, so these otoliths will also be moving in the semicircular canal, which can cause problems, which can cause vertigo. So this condition is basically known as benign paroxysmal positional vertigo, right? Is that clear? If we have these small stones, carbonated stones, otolith present within, okay, the most common location is the lateral semicircular canal, right? So once we have detachments of these autoconia, they are present in the lateral semicircular canals as an otoliths. Now, for example, if an individual is changing his head position, these otoliths are also going to be moving, which is going to cause vertigo. And this condition is basically known as benign paroxysmal positional vertigo. Is that clear?
Yes.
Okay. So there is a test which is basically used to diagnose this condition, benign paroxysmal positional vertigo. And that is basically known as Dix Hall pipe test, right? So in this test, what we are going to do, we are going to tell an individual to, like lay down. We are going to change his head position to 90-degree, right? And if the head position is changed to 90-degree, he will be experience vertigo. The idea is really clear. Why? Because we are basically, like compelling that otoliths to move within the semicircular canal and in turn giving us a vertigo. Is that clear? Hello?
Sorry, what's the name of the test again?
That's known as Dix Hall pipe. Dix Hall pipe test, right?
Okay, thank you.
Okay, so simply we are going to tell an individual to lay down, okay, and we are going to change his head position. If again he's experiencing vertigo, is basically a diagnostic test for benign paroxysmal positional vertigo. The word positional means that whenever an individual is changing his head position, he'll be experiencing vertigo, right? So basically, we have like several difference between peripheral vertigo and central vertigo, right? So the vertigo which is basically seen in this condition, benign paroxysmal, there are going to be certain variants of that, right? Like for example, we are going to have like this is going to be due to change in the head position, right? And simply this vertigo, which is basically produced due to this condition, the peripheral vertigo, is going to have like two components, the fast component and the slow component. So what do we mean by the, like we are also going to have nystagmus as well, right? Vertigo and nystagmus can also be seen in this condition, right? So the nystagmus, it can have like a pure torsional or vertical nystagmus, for example, like it can move in a torsional way or in a vertical way. And in turn, that nystagmus will be having two components, the fast component. Like for example, if you have a right-sided nystagmus, right? What is basically nystagmus is basically oscillatory movement of your eyes, right? So what like whenever we are saying that we have right-sided nystagmus, so basically we have a fast component, right? So this, like for example, if we are saying we have right-sided nystagmus, it means that the eyes are moving to the right side fast, and then they're slowly coming back. Fast to the right side, slowly coming back. Fast to the right, and slowly coming back, right? So whenever the fast component is, if it's like to the right side, we are going to tell that it's a right-sided nystagmus. If it's the fast component is towards the left side, we are going to term it as left-sided nystagmus, right? Is it clear? Hello?
Yes, sir.
Okay. Okay, then we have our next variant of vertigo, that is central vertigo, right? So you guys are already aware of central vertigo is basically due to problems within the brainstem or cerebellum, right? So whenever we have problems with the cerebellum, if you guys remember, we have a flocculonodular lobe, which is important for the balance. If we have problems there, an individual again can have like, for example, due to stroke, due to like vestibular nucleus dysfunction, we can have, or demyelination, we can have central vertigo, right? So the findings again would be nystagmus of any direction, looking towards the fast component, and visual fixation. So remember, one of the differentiating feature of, like, if you want to differentiate the nystagmus, the peripheral and the central nystagmus, remember in the peripheral nystagmus, basically if an individual is fixing his eyes towards certain point, this nystagmus is going to be improved, right? So the eye fixation is going to improve the nystagmus in peripheral vertigo, while in case of central vertigo, fixation of eyes won't improve nystagmus, right? Is that clear? Hello? And in
Yes.
the central vertigo, as we discussed, it can be due to like problems within the cerebellum. So we are also going to see like associated signs of like ataxia, dysmetria, loss of tone, and things like that. Okay. So this was all about ear, and it's a small module. So we are already done with neuro. Tomorrow, Dr. Taha is going to discuss pharmacology section. Then we'll be having a big kind of boot camp session, if you guys know, right? So remember, this time the bootcamp session will be like quite explanatory. So it will be like a big session. So I'll be just hoping you guys to be there, and then we are going to have assessment, right? So to congrats, by the way, we are already done with like neuro. Neuro is basically considered to be the toughest and biggest module of your USMLE step one, right? So we tried our best to convey it in like best way possible. Hope so you guys enjoyed. And tomorrow we are going to have like pharmacology, right? So you guys are already like only left with two systems. Right after this system, we are going to start GI and our repro, right? And then we'll be like transitioning towards a second phase of our preparation. That is, we are going to discuss the minors, and along with that, we'll be practicing NBMEs, and we are also going to do revision, right? So we'll be having a daily boot camp session in the second phase of preparation on every alternative or daily, okay? And we'll be having like so that's basically going to be your dedicated, and we are expecting you to put like at least 8 to 9 hours of your dedicated time, right? So that's going to like decide if you are just prepared for your exam and things, right? So we have also like, we are also currently launching the research. So research will also be included. So you guys are going to give like at least 10 to 20 minutes daily on daily basis to the research, but just get yourself prepared for the second phase of preparation, which is very near. We are going to transition to that phase, and we are going to like extremely enjoy that, believe me, right? So thank you so much for staying here, and tomorrow just get ready for your pharmacology sessions. Thank you so much, right? And see you tomorrow.
Thank you, doctor.
Thank you. Welcome.
Thank you so much, doctor.
Thank you,
Thank
Ahmed.
you again. I like the recapping. Appreciate it. Thank you.
Thank you so much, doctor.
You're welcome. You're welcome. Thank you so much. Thank you.
Thank you, doctor.